Okay, slides. In the meantime, I'll try to make a brief overview. So, as you know, the first clinical study about cross-linking was published in 1993. These are three brave experts, Wallensack, Sperl, and another one. And so many years have passed since I made my first experience back in 2003, but the first experience in Italy was in 2004, and we presented a paper at the SOI conference, and then the first Italian publication appeared after 2 years of follow-up. And then in our team, in our group of co-workers, we have been working with several surgeons, and Dr. Mercucci, for instance. We published a lot with her, and we've studied a lot and researched a lot. So cross-linking by now has become a fact. It's a well-defined fact with a very clear-cut therapeutic role, as well as a well-established treatment, which is universally accepted and demonstrated by now. So to stabilize ectasia, primary and secondary, in over 90% of treated cases, a low rate of complications, less than 3%, and less than 8% failure rate. So you know that very recently cross-linking has been approved of by FDA on April last year. We are talking about conventional 3 milliwatt cross-linking. Many have been worrying about complications, HIV related, and but of course we have some rules to be followed. That is to say, in the post-op, observing a compaction of the stroma of the tissue and visibly the biomicroscopical response of cross-linking, at least in the first 12 months in the post-op, because such persistent scarring haze has a very low incidence rate, less than 3%. Okay, so we have all the indications, so the pellucidar cases and iatrogenic cases, and so we know that for the keratoconus first and second stage or grade and progressive, okay, then we have cross-linking plus, which is gaining ground, and also with refractive enhancement, and then of course the deep lamellar dog. So I have left some room for PK because it might have a few indications. So the main target are pediatric cases, so children. This keratoconus in children has a faster development, and so our main aim is to have a very quick diagnosis and without waiting for a progression, because in children the progression rate is very high, the likelihood is very high, and especially this is true if children are allergic. The association between keratoconus and allergy, if you find it in the patient history, probably is present in above 50% of cases, and these patients are extremely delicate in terms of progression and acute hydrops as well. So I have shared with Dr. Price this cover story on very thin corners, and I take the liberty to share with you the conclusions. So preschooling screening tests are absolutely crucial. That's something we all can do. So going into schools where there is a low incidence of the disease, because all or the majority of patients who received cross-linking didn't need any transplant later on. So all these are the outcomes of Crosslink. More than a decade of follow-up, so more than 10,000 treatments, above 1,000 cases published, the improvement of the visual acuity, 1-2 Schnell's lines, over a decade of follow-up. So this has taught us that this is an easy, repeatable technique with a good safety profile, and also in post-LASIK ectasia we have a good literature, and these are all the reports that were published, above 300 cases published in the literature on post-LASIK ectasias, and we have an increase, so an improvement of the visual acuity and a good efficacy and safety profile. Today we will hear about accelerated CXL, and that's a long, because CXL is a long procedure, and so trials have demonstrated that biomechanically speaking there isn't any significant difference if the therapeutic window ranges from 1 to 3 milliwatts. The energy is always the same, that is to say 5.4 joules being delivered to the cornea. So observations are underway by several research teams. Here you may say several demarcation lines. You know that the demarcation line has always been considered a tangible efficacy sign for cross-linking, and today we can also have patchy CXL, but pachymetry-guided cross-linking. Okay, let's talk about accelerated cross-linking. That's a reality. So protocols 9 milliwatts, 30 milliwatts, and 18 milliwatts, so around 35%. The one that has proved to be more safe, most safe and effective, it's 9 milliwatts in 10 minutes. So today, actually, we can really perform CXL in 20 minutes between imbibition and UV delivery. And I wish to close by showing this recent paper. So 10 years have elapsed. What's the result? So according to the Dutch registry, a reduction by 25% of corneal transplants ever since CXL has been introduced, and especially early diagnosis. So in our experience, it's 30% less transplants in Siena ever since we started with early diagnosis and CXL. And so I believe that CXL still today, although it has already been approved of, isn't a rigid or fixed procedure. Protocols may still be modified, but these modifications must be done after controlled studies and accurate research work. So I thank you, and the next appointment is next international conference to take place during the